Thank you. Again, don't be misled by the environment and the allure. We're here to work. And as you know, some of these areas of patient safety are obvious, and then there's some that are hidden and are not so obvious. So I want to thank Joe for giving a voice to what our panel is going to be discussing today, which is issues of transfusion and blood transfusion. And although we may be a small voice and not well recognized in this arena, let me assure you that together we're going to be loud. So thank you, Joe. I also want to thank Mark Chassin for transforming the Joint Commission from a punitive organization to one with vision and one that's put us on the right direction in terms, not only in terms of patient safety, but safety for everyone in a hospital setting. So again, thank you. And last, I would be remiss if I did not thank Hugo van Aken, who already had an eye on this issue of transfusion years ago in terms of representing a patient safety concern. So again, thank you, Hugo, too, and thank you for leading the European arena. So medical errors that result in harm to patients are not simple. As you could see already, they're very complex. They aren't new. We've recognized that we've been harming patients for years. We just had no tools or good tools that we could, address them in a meaningful way. So managing these, we were essentially clueless. Technology advances that concentrate on early warning and changing trends and patterns, educational as well as leadership efforts to change culture, and hardwiring safety for patients and caregivers is very important to us. And keep in mind that we're all together in this, because hospitals are not just hazardous to patients, they're also hazardous to the caregivers. Many, if not all of us, enter medical field as both nurses and physicians with the desire to help, care, and cure, so we can't forget the many that we help and can't leave those behind. So medical errors can be divided into those resulting in immediate harm, and then there's some that result in what's called delayed harm. These take effect outside of the walls of the hospital after discharge, but the harm that was done or the error that was done occurred while the patient was in the hospital. They can be simple to see, such as wrong side surgery, for example. But then there are those who are not so easy to decipher. It would be the right side surgery, but surgery was not indicated, and the patient ended up with undue harm later in life. Such brings to mind a patient who again died at his 49th year of age. That was Arthur Ashe. For those of you who are too young to know, and those of you who are too old to remember, Arthur Ashe was a champion tennis player who ended up dying after cardiac surgery, receiving a single unit of red cells that transmitted infection to him, with the resultant that later on he ended up dying. So when it comes to transfusion of blood, it's a complex issue which is shadowed by the old concept that no matter what, blood saves lives. The majority of blood recipients could have been managed better, avoiding the potential risks and undue harm, both immediate or delayed. And again, just the way the SPD person alerted, if you will, his superiors, as Mark Chassin reminded us, the reason I raised my hand with confidence was because in our institution, that person would be broadcast to the rest of the medical staff. And I think we need to do that repeatedly. The problem with blood transfusion is that we just release the blood from the blood bank, and then they're on the floor, and patients may receive them without actually having a need. So whether it's neonatal and pediatric patient safety, one panel, failure to rescue, and we've failed to rescue anemic patients in hospitals all the time, again, through early detection, hemoglobin monitoring, diagnosis, and early treatment of anemia. We miss that. Whether it's transfusion resultant in severe infection, resulting in death or severe harm to the patient, all of the moving parts of this summit somehow relate to this panel today. So Again, we talk about suboptimal blood transfusion, but you could see, and this was mentioned before, the proceedings from the National Summit on Overuse. And again, this was a joint effort by the Joint Commission as well as AMA, a Physician Consortium and Process Improvement. And you could see again that in this particular white paper, which was published a year after the meeting, you could see that appropriate blood management was on there, but you could see that there are many other elements of overuse which are described in this. Just last month, I'm sorry, but overuse in healthcare has been not something that's foreign. As you could see, the Institute of Medicine at the National Roundtable of Healthcare Quality in 1980 coined the term overuse. The problem with overuse in healthcare is there's potential for harm to patient. There's excess cost to society as well as to healthcare. Again, if you will, robbing from one side to the other. It defies patients' preferences. Patients want to get the right care, not overuse. And of course, it is a patient safety concern. Now, just last month, the American Heart Association, if you will, as an impetus as a result of the white paper that was just, I showed you, published by the Joint Commission and the PCPI, came out with their summary recommendation. And again, you could see that appropriate blood management in inpatient services. But our job starts before the hospital. We have to take care of patients before they enter the hospital, during their hospitalization, and it doesn't end there. We have to be cognizant of the impact of our care after discharge. Why? Well, why is it that this is an issue with transfusion? You could see that in the United States, this is in 2001, the United States Department of Health report on blood collection and utilization. There was a total of about 13.7 million units transfused in the United States. We're down by about 1 million from 2009. So we are moving in the right direction. You could see the total components exceed 2 million. Red cells in 2006 were transfused at 50 red cells per 1,000 population. That's a measure of comparison between countries, and we're down to 47. We still are the highest transfuser of patients in the world. And that, again, is overuse. AHRQ, in their publication, said that blood transfusion occurred in 1 in 10 of all hospital stays where a procedure was being done, and is one of 5 of the fastest still top procedures done in hospitalized patients. And that's because we're told blood is safe. Well, we're concerned with the patient safety, not with the product safety. So although the issue is that blood transfusions might be life-saving, what we now know is that they can have significant adverse risks. They can be anywhere from fever or febrile reaction to worse patient outcome, including immediate death secondary to a mismatched unit of blood. The problem is that there is significant, and you hear that all along with all the panels, significant variability in clinical practice, which leads to inappropriate use of blood component. The proper use of patient blood management, again, this one centers on the patient and not on the product. Again, interventions will reduce unnecessary transfusion, and the scope of the working group is to review patient blood management strategies in the care setting, improving, again, the right way of taking care of patients, meaning addressing diseases, one of which is anemia. You could see that for us as clinicians, we don't have enough information to have a sensible discussion with the patients. During 4 years in the United States medical schools, you could see we spent about 1 to 4 hours of learning about transfusion. And those who are teaching us, as you could see in the last bullet, 92% reported they were unfamiliar with the transfusion medicine academic awards curricula. This again, so that our teachers are unfamiliar with the curricula, and this is how we're then expected to have a rational discussion with the patient. So you could see that there are problems there. This leads to extreme variability in transfusion practice. Some hospitals for same surgery with the same patient may have 0 transfusion rate. Others may be close to 100% transfusion. Again, the knowledge of fear, learning behavior, all of these are patient safety issue problems. So none of this would be an issue if red cell transfusion had no risks, again, did not have poor outcome. And again, you could see the cost to healthcare and society. So I'm going to go rapidly through these just to show you that the list of risks is enormous. This is just the tip of the iceberg. I'm also showing you that the benefit has not been able to be demonstrated in every transfusion that we give patients. And this is, again, we know that somewhere between 80 to 88% of red cell transfusions show no benefit and may be associated with harm. Cost can be significant. We know that transfusion of red cells could be anywhere from around $500 to over $1,000 per unit transfused to a surgical patient. And when you aggregate that, that could be more than $40 billion annually in healthcare. So what needs to change? The role of physician education. This is the only area of medicine where therapy is central and the patient is secondary. We need to make it safe for the patient, not for the product. Detection, diagnosis, and proper treatment of anemia. 25% of the world population is anemic, of which preschool children amount to about 50% of that. We need decision support and continuous hemoglobin monitoring, changes in hospital leadership, as well as change in practice and the technology. Patient blood management, to show you the definition, is the timely application of evidence-based medical and surgical concept designed to manage anemia, optimize hemostasis, and minimize blood loss and blood transfusion in order to improve patient outcome. Again, we could see that the WHO has adopted this, so we're moving in the right direction globally. We see the American Board of Internal Medicine in the Choosing Wisely campaign has a lot of these do-nots, if you will, in terms of avoiding harm to patients. And lastly, the blood industry has come on board to look at patient blood management, and we're very happy to get them. So all I could say at this point is that we're moving in the right direction. So what I'll do now is like to invite the panel members to come up, and the first one is going to be Bradford Ray. Bradford is Director of Patient Blood Management at Del Sol Medical Center in El Paso, Texas. Dr. Michael Henderson is the Chief of Quality Officer at the Cleveland Clinic Hospital, and is a past, but you never leave that, was a liver transplant surgeon, so he's always going to be a liver transplant surgeon. Dr. Jesse Ehrenfeld, Associate Professor of Anesthesiology, Surgery, and Biomedical Informatics. He's Director of Anesthesiology and Perioperative Informatics Research Division, Director of Center for Evidence-Based Anesthesia, and the Medical Director for Perioperative Quality at Vanderbilt University Medical Center. And he's got more titles than I have. Keith Ruskin, Professor of Anesthesiology and Neurosurgery at Yale University School of Medicine. Elora Thorpe, Patient Blood Management and Transfusion Safety Nurse Manager, University of Kansas Hospital. And you'll see that we go by size. Large comes last is Stephen Thames. He's the Chief Financial Officer in Citizens Medical Center Administration in Texas. So, as we move along in the panel, and by the way, I want to alert you that this is not a HIPAA violation because I got permission, but Michael Ramsey is a patient, right? Why do you think, Elora, he refused blood?
Well, a couple of reasons. One, definitely related to the risks associated with blood. Some patients don't want to be transfused because they've either had an issue before or for religious or personal reasons, but certainly the risks associated with transfusion, everyone thinks about it related to HIV or hepatitis. You want to transfuse a patient and they'll say, am I going to get something from that transfusion? And possibly that's a risk, 1 in 2.5 million. Certainly in 2010 in Missouri, we had a patient that did contract HIV from a transfusion. But those are not the only risks associated with transfusion. Those are things that at least can be tested for, but there are many things that we can't test for. We don't even have a test for them. And so The number one killers related to transfusion-related acute lung injury, transfusion-associated circulatory overload, those are like 1 in 5,000 and 1 in 64 for every transfusion. So the risk is much, much greater for those things that we can't test for than the things that we can. And so what we like to say really is the safest unit of blood is really the one that's not given.
So with that knowledge, Jesse, do you think that there's been any increase in awareness, not only in the anesthesia community, but also in the medical community as a whole?
I do. I think since the 1999 TRIC trial came out in the New England Journal and we started to recognize the risks of giving patients, critically ill patients, patients coming in for surgery, blood, that we have started to change. We know that the FDA data shows that TRALI, transfusion-related acute lung injury, is the single most problem from a morbidity standpoint with giving blood to patients. Certainly, as you mentioned, there are patients that are exposed to infection. Nobody thinks that infection is going to happen to them when they get a unit of blood. I actually worry a lot about the immunological effects that happen when you give a unit of blood. We know, and there's increasingly growing data that shows that when you give a unit of blood to an ICU patient, that they have, for every unit given, a 10% increased risk of getting a nosocomial infection. That's a huge problem. Again, I think as that literature grows, there is this awareness, but we still haven't gotten to where we need to be.
So Steve, do you think that as a CEO, how do the administrative team view this issue currently? Or has it reached that level? Because as I said, this is not one of the major recognized issues in terms of patient safety.
Well, part of the discussion we've had today and yesterday was about the data fatigue and alarm fatigue, and I've recently been promoted to the CEO of the hospital, and within the first 2 weeks of being at the hospital, I received a utilization report, and our blood utilization was extremely high, and the rest of the administrative team were unaware. So they've seen it and really didn't correlate the utilization of blood to safety. It was more of a cost issue, and so we've had to educate the administrative staff as well as some of the medical staff that overutilization is a safety issue, and we need to do something about it.
Thank you. So back to you, Laura, in terms of as a nurse and as a frontline person, if you will, how does the nursing community view this issue at this point, and are they aware of all these issues that we just addressed?
Well, I guess I would say nationally, it's sad to say the nurses are not aware. You know, blood transfusion has always been taught as a task. It's just a task that you do, as opposed to it really being something that's, you know, we teach our nurses it's the most serious thing that they will ever do in their practice is hang a transfusion. It's one of the most dangerous things that they can do. It requires a consent. It requires many things. So what we've had to do at the University of Kansas is really train our nurses to really understand transfusion and what that really is, that it is a tissue transplant. It is the only transplant in the hospital that a nurse is actually performing, and so they have to treat it as such. And so with that, we empower them to look for adverse events and everything. We know there's an adverse event rate of about 1 to 4%. That's normal for transfusions. But what was happening, which we didn't expect, was the physicians would say to the nurse, well, that patient is not reacting because we're not sure of the reason really. And so we had to teach them you can't diagnose that at the bedside and allow the nurse to have full power over that.
So one of the issues that we see, which is a concern in terms of the patient, is the enormous variability in transfusion practices. And Michael, as a quality officer, do you think that there's a difference between academic centers versus, say, rural and small hospitals or private practice in terms of behavior when it comes to variability in transfusion?
No, I think the variability is across the board. Now, there's not a lot of data out there, but there was a fairly good study in Annals of Surgery last year from the University of Rochester that looked at non-cardiac surgery populations across academic medical centers, and the variability there was huge. They looked at colon, hepatobiliary, and joint surgery, and the rates were ranged from 20% to 70%. So the academic centers have got huge variability. Don't tell me the community hospitals are different. So I would not label this as one or other being worse. Everyone's got variability. And the common denominator really is, do you or do you not have a blood management program? And that, although they didn't prove that was the most critical variable, that clearly was the direction it headed. It wasn't about size or complexity. It's about, do you not have a program? I'm sure we'll come back to that.
Well, thank you. So, Brad, as we're hearing about variability, we're hearing about also some of the concerns we have with transfusion. There is some silver lining, if you will. I show that there has been a drop of close to 1 million units transfused. Where do you think that trend is going, and where do you think, or why do you think that trend is there?
That's a great question, and it's a good observation that's been published, because the blood banks are trending this. They're very aware of what's going on in their industry in that perspective. So because of that, they're getting more compliant with the aspects associated with blood management. The system we use in Texas is offering, of the 6 seminars to be held in the 6 months of this year, 4 of them are on blood management. So they appreciate that the proverbial handwriting's on the wall. I think also a lot of clinical studies that are being done now are introducing information that people are becoming aware of that they haven't known before. I'm the abstractor for SABM, and I noticed one of the articles that just had come out, Chatterjee wrote a paper in JAMA, in the internal medicine section of that in late 2013. He did a meta-analysis on 10 observational trials with over 200,000 patients with acute coronary syndromes. And that's always kind of been the third rail when it comes to the treating in medicine. But when he did this analysis of transfusion versus no transfusion, what they're able to come up with was all-cause mortality increased 300%. And the absolute increase was 12%. So if we look at that, are we willing to say of the 200,000 patients that were analyzed, we're willing to let 20,000 die? Now, that's something to really think about. And then it also increased myocardial infarction by 200%. Now, this is fascinating information. And I think as physicians are becoming indoctrinated, if you will, through conferences like this and others, they're becoming aware of the fact that we need to be judicious about this. So I think the answer to the question is, we're getting a general consensus that less is the new more.
So again, this has to do with overuse, and I'm glad you circled back to the question. I also wanted to know from you, since you run a patient blood management program, just for the edification of the audience, I think it's important for us to distinguish between blood management and patient blood management. If maybe you want to just take a second to address that.
Yeah, the aspect on patient blood management is we're doing, as was mentioned in the outset in your comments, we're putting the patient first. And we're allowing them to look at that. Blood management many times is looked at from the perspective of the laboratory and the management of the use of blood. Patient blood management is, do they actually need that product? And if they do, which one, how much, and what diagnostic tools do we have available to help make that determination?
Thank you. Jesse, in terms of what we just addressed in terms of transfusion overuse as well as variability, in spite of all that and the awareness of doing potential harm to patients, why do you think this is not as moving as quickly as it should?
Sure. I mean, the variation that persists despite the availability of practice guidelines and growing body of evidence is certainly problematic because we know that it's causing excess harm as well as it's expensive. Blood is a precious resource and that can't be forgotten. And while guidelines can be an effective way to improve the care that we deliver in some settings, they have been ineffective, unfortunately, in reducing the unwarranted transfusions that are happening right now in our hospitals across the nation, across the world. And I think that's really due to 2 factors. One is that it's complex, right? There's no single predicted or prescribed transfusion trigger that is appropriate for all patients in all circumstances. And also, second, many physicians still remain unaware of best practices and those guidelines that they can use to take care of patients.
Thank you. So you addressed the issue of something called a transfusion trigger rather than transfusion decision, which I think is, again, an important distinction. But the reason it's a trigger is because we use hemoglobin, which is the major driver for patients receiving red cells. So Keith, you've been talking about this for quite a while, talking about hemoglobin as, quote, a trigger or the reason for a transfusion. And maybe you can expand a little more in terms of, as an individual physician, on the role of hemoglobin in the decision-making for transfusion.
So, well, thank you very much. And actually, before I answer that question, I want to back up for one quick second and
Just a small ad.
Small digression. Last year, during this panel, one of the things that I committed to was to create an environment where we could do some more academic research and teaching to answer some of these questions. And as a result of that, I'm happy to report that I just had my application for Patient Safety Fellowship at Yale University approved. So we're actually going to start advertising for that position when I get back from this meeting.
Before you go on, let's urge everybody to sign up.
Got great benefits. So to answer your question, yes, I think there are a number of questions regarding transfusion triggers. One of the things that I found in my practice is that there are 3 reasons that people get unnecessary transfusions. The first is the lack of a laboratory hemoglobin value. You don't know if the patient really needs a transfusion, so you make the decision to give a unit of blood he might need it, and I'm afraid to wait for the laboratory value. The second reason is you have the hemoglobin value, but you're not using an evidence-based transfusion trigger. And then the third reason is that you have a laboratory value that suggests that the patient might need blood. They meet that criterion. You have an evidence-based transfusion trigger, but the patient doesn't actually need the unit because they're no longer actively bleeding. And one of the things that I like to teach my staff about, and one of the things that I like to think about, is last year an extensive meta-analysis showed that there's no real difference between using a restrictive transfusion trigger and a liberal transfusion trigger. A restrictive transfusion trigger transfusing around a much lower hemoglobin value is just as safe as exposing the patient to an unnecessary transfusion. And in fact, probably more safe.
So again, I think that the availability of the measure of hemoglobin, whether it's either continuous or whether it's a spot, allows you to make a decision rather than just using it as a trigger. I think that's a very important comment to make. At least I feel that's very important, that this should be really a risk-benefit weighing rather than just here's the number and we cheat the number, which is what happens on many occasions.
Exactly, and again, I think the key word is making a transfusion decision. It's not a simple value of looking at a number and comparing it to another number and and transfusing or not. You really want to make a clinical decision, and that decision should focus around what's best for the patient and what's safest for the patient. And with the growing body of evidence, particularly some of the evidence that Jesse talked about, but you can go back and look at studies from 1999 that show that there is harm to transfusion, and we may not see that harm because we take care of the patient. We see them in the post-anesthesia care unit. They look great. We congratulate ourselves, and yet 3 or 6 months later, they may have a problem that would not have happened had we given that unnecessary unit.
So Keith, the previous panel that was run by patient Michael Ramsey, one of the participants talked about the fact that there is occult bleeding, whether it be in obstetrics or in the surgical or medical or pediatrics even. How can technology help us in that area to avoid over-transfusion or even to avoid exposure to transfusion under those circumstances?
Well, I think that, again, if you use continuous hemoglobin monitoring, this is a relatively new technology, and it's still in the process of being validated, but most of the studies that are coming out show that it's useful. And certainly, I use it in my practice, and I use it to drive the decision, not so much to give a transfusion based upon a number, but the decision to obtain further laboratory values. The flip side of that is you can use it as an early warning system, and I've had a couple of surgical procedures now, and again, we talk about occult bleeding, where the patient was bleeding but was not obviously bleeding into the surgical field, and one of the first signs that we had was an unexplained drop in the hemoglobin on a continuous monitor that then, number one, suggested that maybe we did need to considering blood products, but number two, and more importantly, allowed us to alert the surgeon that there's a problem here, you need to look at it.
So I think that we're talking about hemoglobin, which is a laboratory measure. And we talk about transfusion, which is a therapeutic intervention. What's the disease, Michael?
Well, I think the triggers are important, but I think we've got to be careful not to aggravate it. And I think one of the things I think there are opportunities around is prevention. How do we not make the matters worse? And we've had an interest over the last couple of years looking at what we've called hospital-acquired anemias. So looking at a large population and really using one of the large data sets, the University Health System Consortium data set, we looked at 400,000 admissions over a 3-year period in our health system. And 180,000 of those patients actually were not anemic coming in. So about half of them had a degree of anemia, we had WHO definitions. Of those who weren't, 70% of those by WHO definitions became anemic during their hospitalization, 30% of them significantly so. Okay, we do a lot of things. So I think we've got to think about other things that we should not be doing to not aggravate the problem and precipitate towards the need for transfusion. And it is the things like, are we drawing too much blood for tests? Do we need to draw all the tests we're doing? The volumes of blood we draw for the tests, are we overdoing it? And certainly we've gone to small volume tubes. I'm sure many places have. Do we need to do all the blood gases we do? I think it's just by habit, by rote, this is how we've always done it. I think it's things like the over-resuscitation. My anesthesiology colleagues, some of us have known we call them the aquatic assassins. The over-resuscitation, sorry, I couldn't help it, but
let the record not reflect that, please, yes.
But joking apart, I think sometimes we do push it a little hard. Yeah. So how do we really get the right balance in these situations? So I think trying to prevent some of this is important. And I think back to your point, sometimes we just don't know when there's more blood loss than we realize. I am a surgeon, and yeah, you always deny you're losing a lot of blood. So I think understanding that balance becomes really important. But I think we've got to be a little careful not to go too far the other way. And certainly our cardiac surgery group have looked at that in some detail, but they had a very, we will not transfuse approach. And in doing that for a significant number of patients, they found that there is a nadir below which mortality, length of stay, prolonged intubation, you can get into the cycle in the other direction. So certainly it's back to the individual patients with some of these triggers that are going to help get you there. But my plea a little bit at the moment is let's try not make it worse when we get the patients in the hospital. There's an opportunity, I think, in that space that could be more broadly applied.
So we know that patients now come into the hospital. There's a significant population have anemia, which is a reduction in hemoglobin. And if we look at that previous panel, the question, of course, is how do we get them through the hospitalization without having them exposed unnecessarily to transfusion, and what the thought of continuous monitoring of patients for hemoglobin during hospitalization. What's your thought on that? And Steve, you can, as an administrator, how you look at that too?
Yeah, but I think it's about the individual patient again. It's about why are we looking at this, and why is the hemoglobin there? It's the oxygen carrying capacity. Are we really perfusing the patient appropriately? And I think it's that balance of those risk factors that becomes so important. And certainly of the population who come in anemic, again, another bad to worse situation really starts to occur. That population, with a lot of the things that happen when they come in, I think one needs to be monitoring, following carefully. Whether it's the continuous monitoring, depends on those individual patients. In some situations, yes. In others, no. This isn't just a surgical problem. This is a medicine problem too. So I think the patient, watch the patient. People are an important part of this. It's not all the technology.
Right, so I think, again, monitor is a tool that helps us. It's only one tool, but it requires resources.
Right, and I was going to say collaboration and inviting others to assist with that decision and working with the pathologist to say, hey, do we need to infuse 1 unit or 2 units? And that's some of the discussions we're having at our hospital is that when blood's being ordered, that we're asking the question, okay, what's the need, what's the indicators, and just asking the questions as I've already had significant impact in the reduction of transfused units. But just knowing that there's more people on the team that you can consult with prior to making that decision.
So again, we just heard that it's got to be a multimodality approach to it. So the patient gets admitted with anemia to the hospital, and unfortunately, the default currently is if you're anemic and you reach a certain trigger or low hemoglobin, the treatment is going to be transfusion. What about patients coming into the hospital being identified as having anemia, getting early therapy that's appropriate? How would you manage that, Elora? I think you have some experience.
Right. Well, we've developed an anemia clinic, as some hospitals have. One of the issues is that, be in trouble here with the physicians, but that physicians, especially primary care physicians, see anemia as a destination. So people come in, they tell us they've had anemia, they've had it for years, it's never been treated. So we talk about blood being bad, but we know anemia is bad as well. And so really that should be treated from a primary care standpoint before the patient comes in, so that when you get that open heart patient or the orthopedic patient, they're not anemic by the time they get to you. But if they are, then we try and treat them over a course of a few weeks. We bring them into the anemia center, and we have a joint practice protocol with our physicians where our nurses do that treatment. We have anemia management coordinators that do that. Bring the patient in, give them the iron and erythropoietin therapies that they need several weeks prior to surgery, and then try and optimize them for surgery. Because the one thing that we know is that the hemoglobin that the patient goes into surgery with is what determines their risk for transfusion. So if their hemoglobin's low, then their risk for transfusion will be high. So if we can prevent that, then that's what we do. The difficulty with that is that if the patient doesn't understand why we're doing it, then that patient will want to go down the street where they can get it done today as opposed to 3 weeks from now. So that's the part, bringing in the patient to the whole situation so that they understand the reasons why we do it.
Thank you. And Jesse, thinking about these modalities for treating anemia other than transfusion, what do you think is the awareness in the medical community of these agents and their usefulness?
Yeah, I think there's some awareness of their utility, but we don't have certainly any standardization of widespread preoperative protocols to try to address it. Unfortunately, I think we view anemia as a lab value, not as a treatable preoperative medical condition, and we need to change that. And I couldn't agree more with the comment that we need to engage patients so that they understand that they've got to partner with us to help optimize their movement through the system to reduce the harm that ultimately could be caused if they get an unnecessary blood transfusion.
So again, going back to the issue of tools and monitors that can alter behavior, I know that at Mass General, when you were there, you evaluated the impact of continuous intraoperative non-invasive hemoglobin monitoring. And if you could just share with us some of the results of that, I think that would be of interest to us.
Sure, yeah, so we did a small prospective randomized controlled trial evaluating not the accuracy of non-invasive hemoglobin monitoring. We believed the FDA data and what Massimo had previously demonstrated to get it approved. I was interested in how people would respond, react to it, and change their decision making. And so that was really the goal of the trial. And we essentially randomized elective orthopedic surgical patients to having usual care or usual care plus the non-invasive hemoglobin monitoring during the anesthetic, and we had some pretty profound results. We reduced statistically significantly the rate of red cell blood transfusions during the OR from about 4.5% to less than 1% for those elective orthopedic surgical patients. And so in my mind, it can be a very useful tool in the right patient population.
And Keith, I know you use it also in terms of decision making. What's your opinion of the results that Jesse just shared with us?
Well, I think that what Jesse just mentioned demonstrates the importance of this and how well it works. There's another really interesting study by Awada where he looked at the use of non-invasive hemoglobin during neurosurgery, and I'm the director of neurosurgical anesthesia at Yale. And what he found was that just by using this monitor, he was able to reduce the average number of units transfused by almost half, from 1.9 units to 1 unit. Now, the other interesting part of that study is that when a decision to transfuse was made, he was actually also able to decrease the amount of time that it took to make that decision. So you're both eliminating unnecessary transfusions while at the same time you're getting the blood to the people who need it more quickly.
Thank you. So in terms of the efforts, not just to reduce transfusion, which I think, Michael, you addressed, it's really an effort of identifying the patients who are at risk and seeing if we can modify that risk, both in the surgical and non-surgical patients. As a hospital administrator, how have you been successful in getting all the pieces together to try to change that behavior, if you will, or to increase awareness amongst the providers?
A key component I've found is having a champion, and Sammy Sue Hendricks, our lab managers here, and she is such of a champion of this cause, and seeing the effects and the negative outcomes, and going to the physicians and taking a personal interest to educate the physicians on the effects of blood transfusions and how can we impact quality patient care and make it about patient safety and not about finance and money, because typically the approach is you're just trying to save money because blood's expensive. Well, that's true from a hospital administration standpoint, but they're not mutually exclusive. So you can have safety for your patients and also conserve your resources for other uses.
So Elora, thank you, Stephen. I think that, again, putting the right tools in the hands of people, as well as trying to clarify the difference between preventative care as well as rescue care, which is what I think a transfusion may end up being. Your role as a patient blood management manager, as well as a transfusion safety nurse or officer, if you will, how does that differ? And is it, how can you explain that in terms of that we understand the two roles, or if they're synergistic?
They're completely different, actually. One is focused on prevention. Patient blood management is focused on prevention of that transfusion at all. And transfusion safety really is exactly what it's called. It's the safety of the transfusion. We like to say from needle to needle, from the time that it's donated until the time that you take the needle out of the patient that you gave it to. So the first part of that is owned by the blood bank and the blood centers. And then the second part, which is the majority of the patient risk or the patient safety, is the administration of the product, which actually is something we've never really concentrated on here or in any other country, because no one really told us that we needed to concentrate on the administration of the product. So what I spend a lot of time doing is really out clinically with the nurses, looking at how fast did we give that transfusion. We know the reason for transfusion-associated circulatory overload has to do with how fast we give the product. How does the doctor usually write the order? Give it as fast as possible. What we know now is that is definitely not true. We should not be doing that. So we look at length of time. We look at, are the nurses appropriately taking the vital signs? Can we see within those vital signs that we review retrospectively whether or not there was an issue that we missed related to transfusion reaction? And then the other thing that I do is I work with our pathologists and blood bank partners in making sure that before that blood leaves the blood bank, that it was appropriate. And so we review every single transfusion that's ordered and the indication. And if there's an issue with that, we call the physician personally, or our nurses will go up and see the patient, and then talk to the physician, and then make a decision on that transfusion.
So I'm going to go a little bit off script and open a question to everyone, which is, what do you think should be the role of blood bank and blood center in hospitals and outside hospital in terms of promoting patient blood management, appropriate transfusion, and preventive care, which again is the management of anemia? Brad?
I think that if a blood bank wants to stay relevant, they're going to have to keep up with the adjustments and the changes that are occurring in medicine. And organizations like SABM are pushing analyzation of transfusion before it's done. And I think blood banks are beginning to circle around and appreciate the importance of that. So if they want to stay in business, they need to be relevant with what's going on and be able to offer education on options and appropriateness of transfusion.
Anyone else? Yes, Mike?
Well, I think it's all part of the team. I think patient-centered. It's about what we've talked about. It's about the assessments, it's the preventions, it's the decisions. But the blood bank is certainly an important part within that total team activity. Mm-hmm. And I think the risk is working in silos. We've got to break that. And I think we are breaking that. I think it's very different now to how it was 10, 15 years ago. Right?
At Vanderbilt, part of the way that we've been trying to break down those silos is to give our clinicians back comparative data that they can use in real time. We swim in too much data, and there's so little information. And part of our recent work has been how can we give sort of near real-time performance data back to surgeons so that they can see how they're doing as soon as cases were done. Nobody wants to be the surgeon that loses twice as much blood or the anesthesiologist that transfuses twice as much blood. We respond to those comparative social norms, but we can't if we don't recognize what's going on. And so that's some work that we've been engaged in. I think that's also an important part of breaking down those silos. That includes the blood bank, of course, as well.
So I think there are a couple of issues. I think number one is that there needs to be a lot more education. And I'm going to go back to something you said at the very beginning, where anemia is one of the few things where where the disease is a number. In fact, the disease is not a number. The disease is impaired oxygen carrying capacity. And I think that's what the goal needs to be, ultimately improving oxygen delivery and oxygen carrying capacity to get the oxygen where it has to be at the end organs. That said, I think that continuous monitoring is something that can potentially help, again, because it gives you the tools to avoid transfusions when you don't need to do them, while at the same time it can potentially give you an early warning system that something may be amiss and we need to take further action to help the patient, which may be a transfusion or it may simply be alerting to the surgeon to the fact, I think you've got some unrecognized bleeding either during the procedure or after the procedure. And afterwards, if anybody wants to come to me, I have some experiences where continuous non-invasive hemoglobin has enabled me to alert the surgeon to a problem before anybody else realized anything was going on.
And certainly we've partnered with our community blood center with looking at outcomes data. We know that if we reduce transfusions, patients do better, but we don't necessarily have really good data around outcomes. And so we're working on creating a database for that. That's been very helpful, that's something they've taken on. I think just like the comment was about, we've reduced transfusions so much in our area that has been somewhat detrimental financially to the blood centers. And so them helping us and partnering with us on other things other than just the product has been really good.
And generally, due to the lack of competition in some areas, the blood bank you have one option. And so they're supplying a product based on the demand, and you still cannot administer a unit of blood without a physician's order. And you typically, the center of the utilization issue from a hospital standpoint is working with the physicians on developing criteria and utilization guidelines, and again, collaborating to say, what are the resources available to help make a better decision?
So since this was an open question, a member of the panel, I'm going to take an answer too, and I'm going to say that I think that when we're looking at blood, one of you mentioned it as being a transplant, if you will, or like a transplant. At the same time, blood or a bag of blood is viewed as a medicinal or pharmaceutical because we treat it that way. We can order it and we can administer it, not just like a transplant. So in fact, we're talking about medication errors in some sense, and the activity of a blood bank should move, in my mind, from being retrospective analysis after an injury occurred to prospective analysis. Does this patient need this particular component, or are there other ways of doing it with less risk and better outcome? So I think that as we look at this issue of red cell transfusion, one of the questions, of course, that was raised early on had to do with variability of transfusion. And variability in any area of medicine is usually a cultural issue rather than a science. So, Michael, as a quality officer, do you think that you could change behavior at this point?
Yeah, you can, you have to, and I think it is part of what's happening. It is the culture. And certainly, having a good blood management program, it's about the component bits that are going to drive that change. It's things we've talked about. But I think it is having a commitment that there's something going to fix. We had the dubious distinction of being #1 in red cell use in the country 10, 15 years ago. Our CEO, cardiac surgeon, got religion early in that while he was still operating as a cardiac surgeon to reduce blood transfusion. But when he became CEO, it became a real issue for the hospital, the enterprise as a whole, to reduce transfusion. So that leadership component to say, I'm watching, we're measuring, we're collecting data, we're giving feedback to all the physicians, not just the surgeons, on their red cell, on all their product usage is important. Taking it a step further to really reduce the variability, I think is hugely important too. Individuals respond to data. And I'll give you the example of our orthopedic group, who not just looking at transfusion requirement, but just looking to standardize practice in their total joint replacement. And you sit 15 orthopedic surgeons down in a room, it's hard to get consensus. I was a little skeptical, but indeed we have.
Yeah.
And I think it's important because I think it's patient-centered. But one of the side products of that movement over the last year, where they have agreed about indications for procedures, how they do them, their post-discharge follow-up, who goes to rehab, who doesn't. One of the side benefits of that is their transfusion rates dropped in half. They came down 50%. They looked at each other and said, no, you transfuse? They didn't realize who was doing what. And just the recognition and the standardization was huge.
And it dropped in half without any adverse outcomes.
Absolutely.
Actually, we could show better outcomes in some of the studies that have been done. So we're getting sort of to the end of our conversation or discussion here. And I think that we're seeing good trends. I think that there is commitment, but we still have a long way to go, specifically in this area. One of which, as I mentioned, is really the detection, the diagnosis and treatment of anemia properly. As I mentioned before, about a quarter of the world population is anemic. About 50% of that is preschool children. We know that anemia is an independent risk factor for patients, and I think we need to grab this one because it is a patient safety concern. So as we, this may be a yes/no question, but as we move along, I've got one last question, and that is, do you think that both anemia management as well as transfusion should be a quality indicator?
Absolutely.
Yes.
Yes.
Absolutely.
Absolutely.
But it's got to be, there's got to be a commitment from all parties involved, not just clinicians, not just those engaged in measurement science, not just experts in blood management and patient blood management, but also patients. Patients have to be a part of the equation. It's so important.
I agree. And how can we get patients involved?
I think education, and patients can drive so many things. They drove pre-autologous donation. We don't do it anymore, but that was who drove that particular thing. And so if they request it and they are educated about it, then providing that education for them is imperative.
Great. Well, I think we're about out of time. Brad, you have exactly 20 seconds.
Yeah, 20 seconds. Along with Elora's point, I think that sometimes you can get what's called earned marketing. When you have a new program that's opened up, the news media will come to you because it's a featured story they want to know. And if it's something like anemia management, that's very important. And if you highlight things like the patient safety movement, that's even more important. So we're adding impetus to what we're saying.
Thank you. I think the panel, thank you all on the panel. I think you've done a wonderful job. You're deserving of lunch.